Okay, guys, we're going to go ahead and get started. Let's have a big round of applause for our first guest speaker of the year, Dr. Joshua Greenstein.
So, I'll tell you a little bit about myself and a little bit about what I do. I guess you guys are all interested in becoming doctors, which I think is great. I'm a nephrologist up in the North County, Escondido, Palomar area. Palomar Hospital is my main place where I work, although I go to a whole bunch of different places. Well, when I was your age, I had no idea what a nephrologist is. My wife didn't know what one was until she married me, so it's not like a lot of specialties that are very, like cardiology, that everyone knows what it is. So I'll tell you a little bit about what I do. Hopefully it's a little exciting, but I didn't prepare too much because if you have questions or you want to know what, something, I don't know what you want to know, so I left a bit of time for that. So nephrology comes from Greek nephros, which is basically Greek for the kidney, and what I do is a subspecialty of internal medicine. So I did, after medical school, I did 3 years of internal medicine training, and then another 2 years of nephrology training, a fellowship. Fellowships are 2 to 10 years, depending if you want to do research. Most people don't do, I had to do 1 year research, but some people do more. Basically, it's non-surgical. There are some procedures that I do, but more and more these procedures are taken over by other people. So during training, I do a lot of procedures, and then in the real world, there's less procedures, unless you really want to do it. So I work mostly with the kidney failure. I'm not the other. What I used to tell my daughter when she was a little kid, when she was like 2 or 3. I told her that I was a doctor, and I told her I was a kidney doctor. So basically that's what I do. I'm a kidney doctor, but as opposed to a urologist, they're surgeons. So they do surgery on kidneys, bladders, things like that, the whole urinary tract. I get paid to think about it. They get paid to do stuff, I get paid to think. Although there's a lot of, I end up having to do a lot of urology. There's definitely an overlap. So I end up having to know a lot about not necessarily doing the surgery, but knowing what needs to be done and things like that. Nephrology is, I didn't know what it was when I went into it, but when I went to medical school, but it ends up, it's so wide ranging. Every day I do something different. I do 10 different things every day. If like I'm kind of getting bored of something I'm doing today, I know that tomorrow I'm going to be doing something different, and then I'll be going back to what I was doing. So there's really no chance to get bored in my specialty because there's so many different things that I do on a day-to-day basis. Don't get into a rut. This week I'm in the hospital. It's the end of the week. I'm kind of getting tired working in the hospital. But next week I won't be in the hospital at all. I'm doing something else, and I'll miss being in the hospital. So there's a lot of variation. So it's not there's no boredom. The majority of what I do is dialysis, kidney failure. So a lot of people, you need your kidneys to live. A lot of people out there don't have no kidney function, and until about really 1960s, people who are your age, they wouldn't be alive. Now they live, they get a dialysis, they get a kidney transplant, have fairly normal, productive lives, and so that's the majority of what I do. Sometimes, like in any specialty, there are depressing aspects and not so depressing, but that's the majority of what I do, and I find it very exciting every day. There's a lot to learn about that. So the other things that I do is pre-dialysis patients trying to go off dialysis, getting their kidneys normal or slowing down the progression. that's mostly office work. Transplants, I don't do the transplants, but I manage them afterwards. There's three, most cities have one or two places. San Diego has Scripps, Sharp, and UCLA that do transplants. And then after a couple months, they send them back to us and we manage them. Hypertension, that's a lot of what I do. The kidney is central to high blood pressure, so difficult cases get sent to me. Various kidney diseases, part of other diseases, I manage. Preventing kidney stones. The urologists take out the kidney stones. They're not always interested in preventing them, but they get paid to take them out. But I try to prevent them. And then the thing that I like the most kidney doctors, this is what they like doing the most, but probably 5% of what we do is managing fluids and levels of potassium and sodium in the blood. It's very esoteric and it's very mathematical and intellectual, and we start arguing about it and stuff. But it really, on a day-to-day basis, it's a small part of what we do. But it's interesting. Did I go back? Oh. So renal failure or end-stage renal disease is basically what I do. They're very sick patients for the most part. It can be depressing at times, which I alluded to for a lot of doctors, because a lot of my patients, especially I don't know if you know anyone with kidney failure, as they get older, a lot of our patients are elderly and have a lot of medical problems and have limited life expectancy, but we try to give them quality and quantity of life. And we're, it's so common. People don't realize you're driving past these little mini malls across America. There's little dialysis units, outpatient. People come in, get their dialysis, and go on their way. And nowadays, we try to keep people as normal as possible, keep them going to school, working. We try to, historically they couldn't do that. We try to give them as normal life as possible. That's about half of what I do. And I drive around to different places, and I have to see them on dialysis. I operate a dialysis unit, make sure the water is pure. I don't know if you know what dialysis is, but basically we clean people's blood. It goes through a machine, and I wish I had a picture of the machine, but I don't. And the chemistries in their blood changes, and we have ultra pure water. So the water we have in the dialysis unit is the purest water possible. There's a huge machine with a reverse osmosis filter and ultraviolet radiation, and they end up to kill all the bacteria. And they take basically water out of your faucet and they take out all the chlorine, everything. It's 10 times better than distilled water. It tastes awful. You're not supposed to taste it. It's actually distilled water. It's just so gross. And I tasted it. You see these patients, we had to run 100 patients, which take a hard time, but I also work in the hospital and such. A lot of people in my specialty work in transplant centers. They're subspecialists. But even as a general nephrologist, I manage these patients. And it's a good feeling going to be a transplant nephrologist. People with transplants are generally happier, so it's pretty rewarding to take care of them because they're pretty fortunate. And we have women with transplants and have babies, and people who are living normal lives. It's nice to be part of that. We manage kidney disease, high blood pressure. We measure. There's a lot of esoteric diseases I won't go into because I don't know what they're interested in. That are actually fairly interesting for us to deal with. Small percentage of what we do, but when we see these cases, they're pretty exciting, and you realize that's why we went into it. There's a lot of genetic diseases we deal with, and counts of people with kidney diseases that run in families. Some of them are not treatable, but we use to get transplants. And then obviously diabetes and high blood pressure ends up being like the center. That's what gives me most of my business is chronic kidney disease. When I say business, I say that kind of facetious way. A lot of what we do is hospital work. There's not too many specialists that are in the hospital anymore because everything's outpatient. But I spend a good amount of my time in the hospital. The other critical care docs, cardiologists, gastroenterologists a little bit, not so much. But us, we're pretty much the main specialists other than surgeons. We're talking about internal medicine docs. We're pretty much, us and the pulmonologists are definitely the most.
Jordan G, please come to the Nighthawk Center. Jordan G, please come to Mrs. Sutherland's desk in the Nighthawk Center.
A
Jordan
lot of
G.
people end up in the hospital, whether it's a trauma or something that they have no kidney disease and they develop kidney disease in the hospital, and we get them through that. We manage how much fluids people get, and we're kind of like, we end up kind of being the consultant for the doctors. A lot of times when they're, I'm not talking about myself, but I know a lot of other doctors in my specialty are very smart, and they end up being kind of like the consultant for the doctor's doctor in a way. People get very nervous when people's kidneys start getting worse and they call us immediately. So it feels nice to kind of feel wanted. Procedures, a lot of people like to do procedures. I'm trained to do, we do a lot of kidney biopsies. I don't do those anymore because it's hard to find the time. I was actually okay at it. I'm not good at a lot of stuff, but that was one thing I was okay at. I usually have the radiologist do it. People often need central lines for dialysis. We'll do those sometimes. And there's a new field called interventional nephrology, which is kind of a hybrid of radiology and nephrology, where people come in for dialysis. The way people get dialysis, you have to have a shunt that works. And if it doesn't work, it's kind of an emergency. You have to do dialysis. So either the radiologist, a surgeon, or one of us will open that up and take out the clot and make it work again. I don't do that. It's kind of like a subspecialty that you have to control it. I don't know if I can talk about anything else. There's a lot of good aspects of my field. There's job security, because there's always sick people, unfortunately. Also, people are kind of scared. There's a lot of specialties where people try to manage things like that outside of their specialty, not so much in kidney disease. There's a lot of politics and business aspects of my field that I don't enjoy, but I think that's like that in most fields. There's a lot to know. I'm always learning. And the other thing in my field, this is a field where there's a lot of things we don't know, so we end up arguing. You know, it's nice. I work with 4 other doctors in my field, and we're always discussing cases, emailing other doctors, trying to get the best, what's the best thing to do. A lot of other specialties, people think they know everything and don't want to talk. You know, it's the ego thing, you don't want to talk to other doctors. In this field, you could ask 3 experts in one thing, 3 experts in a certain disease, and they'll all disagree and argue. So it's nice to be in a field where there's a lot of kind of discussion. People are, like I said, people are kind of scared of our patients sometimes because they tend to be pretty sick. So they call us regularly. It's nice to be wanted. Long hours, a lot of driving because I have to go to different. I'm only in one hospital, but I pretty much go to different places where people get dialysis. People get it all over the city, so I have to go to the different places people get it to see them. There's quite a bit of driving. And like I said, you can do a little bit of everything. I don't get bored, because when I do get bored, I'm doing something different the next day. So it's nice to mix things up. And also, you can find your niche. You if you have an interest in something, you can kind of become the expert in it within the field for your group, for your city. Those certifications. So that's all I have, really. I don't know. Is there anything else you want
So if anybody has any questions, that would be fine.
Yeah.
How long did you go to school?
Well, I did, after college, 4 years in medical school, and then my residency internship go together, so that's another 3 years. And then I had a year off, that doesn't matter. And then I took 2 years of fellowship. Fellowships are different. It depends if you want to be a research person and an academician, and you end up going to, for maybe 6, 7 years. A lot of them will make you get a PhD. And if you're interested in doing research, that's great. If you're not interested in doing research, it's kind of a lot of years of training. So there's different, I had to do 1 year of research, so it's just 2 years. Yeah.
What kind of research, or what kind of stuff did you do at your Stanford fellowship?
My Stanford fellowship?
Yeah.
So I did my fellowship up there. I did, most of it's clinical, but I did research in something that is not a mouse. There's a lot of stuff looking at growth hormone in the kidney. So people with kidney failure, that's why kind of this guy from Different Strokes in kidney failure. Harry Coleman, the actor who died. He died of kidney failure. He was really short because he had kidney failure as a kid. So it was looking at growth hormone and in order to treat people with kidney failure. And it almost got approved for that, but people didn't want to be able to get injections. So it didn't amount to much. Got it?
How did you get into this specific field of medicine?
This specific field? Well, I didn't know anything about it. During my residency, the smartest doctors I knew that's what usually happens, is either you're really interested in something or you're really inspired by the doctors that you work with. There were 2 doctors this is at UCLA, brilliant guys. Everyone knew they were the smartest guys. And whenever, not just in the field, just in medicine and period, and whenever they went to them when they had a question. They were always right, and they were nephrologists. And so working with them, they kind of inspire you, and you realize there's so much in this. And then after a while, I enjoyed it myself. And that's basically how I got into it, was role models. So, yeah.
And what was your undergrad major?
My undergrad major, let's see, what was physics. I wanted to be a physicist, and then I realized late in the game that it was enjoyable, but when I really started to struggle with it and the really advanced stuff, I just didn't have the patience to really struggle through it, and it was also very isolating. I wanted to really work with other people and help people on a day-to-day basis. So I figured I didn't want to be a doctor most of high school, college, until I realized
Please report to the
I
athletic
could do
office.
science to help
Try
people on a
B.
day-to-day
Please
basis.
report to the athletic office.
And so that's why I went to medicine. Yep.
As a nephrologist, what other types of doctors do you work with?
In the hospital, we're primarily in the ICU, which are the critical care or pulmonologists, cardiologists. All my people with kidney disease often have heart disease, so I see as many heart patients as the cardiologist. And then nowadays, there's the hospitalist, which is kind of the internal medicine doctor in the hospitals. Those are primarily the people I work with, and surgeons, because they often have patients that develop kidney failure. You know what? They're not really. There's probably, I don't know if there's like maybe 10,000, something like that, 15 maybe in the country. There's around 400,000 people on dialysis. Another, I want to say 100 to 200 with functioning kidney transplant. And then people are living longer. People have a lot of chronic medical conditions. There's a lot of obesity in America and diabetes and things like that. At the same time, our care is much better, so people are living longer, and so they end up getting kidney failure. So there's definitely a need in my field. There's lots of jobs out there, especially in the future. Yeah.
What are some common kidney problems that you
The common kidney problems, the most common stuff, obviously dialysis, but kidney failure. People develop kidney disease from high blood pressure for many years, diabetes, and that's, we try to keep it from getting worse. In the hospital, people develop kidney failure from bad infections, acute kidney failure, and then we have to manage that, or from say low blood pressure, from bleeding. Other things like autoimmune diseases, we deal with. The interesting stuff that I deal with, a lot of autoimmune diseases like lupus and stuff like that cause acute kidney failure, and we have to give pretty strong medicines to shut down the immune system so it stops attacking the kidney. Those are kind of like the zebra, the unusual diseases we deal with, and we do kidney biopsies for those diseases to see how bad they are, and usually argue with other doctors what the best treatment is amongst ourselves.
Could you explain dialysis more in depth?
So yeah, dialysis, there's basically two different types of dialysis. One that you do at home, one that you do in the clinic. The clinic one is basically, you take blood out of your body, so you stick a needle into, basically, not to get too graphic, but you have an artery and a vein. You connect the artery and the veins. You can't stick in the artery with a needle because you're going to bleed to death. So you connect the artery and a vein, and over on a month and a half, it turns the vein into this nice, thick pin cushion that has good blood flow. And you stick 2 needles in it, and blood goes out, one needle, and back the other. And it goes through a machine. And basically, I don't know if you guys take chemistry, there's diffusion. So basically, you have this semi-permeable membrane. One way is this what we call dialysate, which is basically water, that distilled water, I taught ultra pure water, and they mix it with, it's kind of like Kool-Aid, you mix it with a concentrate. This is what we want blood to look like. This is what the level of potassium, sodium, the acid in it, the bases in it. And the other way is blood. It's full of toxins and stuff, and so the toxins diffuse through the membrane into the dialysate and then goes down the drain. And all the good stuff, basically what you want the blood to look like, diffuses in the other way. And so basically all it is diffusion, using it's basic chemistry. And then the blood comes back to the body the way you want it to.
Big round of applause for